Welcome everyone for the class on major trauma. Again, it will be divided into two parts. Today is the first part of the major trauma. When I'm talking about major trauma, it's a polytrauma, what we are talking about, and we will be heavily dependent on the ATLS. ATLS 10th edition is the latest one. So whatever I'm teaching it, it is according to the ATLS 10th edition, which is followed in the NHS. Though ATLS belongs to the USA, it is followed in the NHS. Wherever we deviate from the ATLS, I will let you know, and the reason also I'll let you know. So mainly what we are dealing with is the ATLS. It is the 10th edition of the ATLS. We'll be going much more deeper than what is being taught in the ATLS. Okay, in the book, it might have been mentioned, but when you go for a program of ATLS, they may not have gone to this depth. We will try to go in a depth so that we cover up all the topics and it becomes easier for you to practice as well as answer the questions. Primary survey. When you're doing a primary survey, we go according to an airway, breathing, circulation, deformity, and an exposure. The main reason we are going in a sequential manner is to treat a life-threatening disorder first, the one which might cause the death to a cause which might cause and death needs to be treated first or dealt with it first, followed by the least likely to cause and death. So we are going in this sequential manner so that we can save the lives. So that is the importance of going in a sequential manner. For you to answer the questions also, it is very much important you go according to the sequential manner. For example, when you're dealing with an airway, if you found something abnormal with the airway, you will intervene immediately. Along with it, if required, you will get the adjunct investigations. For example, you want an ETCO2 to be done, you get an ETCO2 done. You want a chest X-ray to be done in the airway, you get a chest X-ray to be done. Same thing holds good in the breathing, in the circulation. For example, circulation is compromised. What you do if the circulation is compromised, you try to stop the bleeding and you will start with a major hemorrhage protocol. Disabilities is mainly the neurological status, what you're looking out for. In the exposure, you expose them completely, making sure patient doesn't undergo or patient by preventing the hypothermia, you'll expose the area what you're examining and suddenly you will close it. First thing what we'll be talking about is the airway. Airway with C-spine protection, what they call it. Okay, but there are steps what you need to follow. Once you receive a trauma patient in the emergency department, the first step is to do an inline manual stabilization. What is inline manual stabilization? This is what the patient, what here the nurse is doing and demonstrating. This is known as inline manual stabilization, what you're seeing here. This is the step one, what you will be doing. The step two is basically assessing the airway, and if required, you will be intervening and managing the airway. Step three is 3-point immobilization of the C-spine. It is not only the C-collar what you're placing it, along with the C-collar, you're placing the head blocks on the either side. Along with it, you are having the tape, one running over the forehead, another running over the shin. So you're immobilizing at 3 different points. This is the right way to immobilize the C-spine. Just using an C-collar is useless. Do not use it just an C-collar. If you want to immobilize the C-spine, the 3-point immobilization you need to do it, which involves head blocks, which involves C-collar, which also involves tapes running at 2 different positions, one over the forehead, one over the shin. So the sequence, remember it, it is tested multiple times in the exam. First one is manual inline stabilization. Second is airway assessment. Third is 3-point immobilization. Few things what you need to remember while answering the question. When they just mentioned that C-spine protection, you can consider what they are talking about is a manual inline stabilization. If they specifically mention 3-point immobilization, that needs to be done after the airway assessment. Because once you have done this 3-point immobilization, it becomes difficult for you to intervene if something is wrong in the airway. For that particular reason, this has to be done after doing an airway assessment. Till then, you hold it in this manner. Mainly the reason why we are immobilizing the C-spine is if there is any C-spine injury, it might get worsened due to the movement of the C-spine. That is the movement of the neck. In certain circumstances, the patient might not be cooperative to any reason. For example, it is a teenager. He might be under drug influence and he doesn't want a C-collar and he's resisting for the C-collar or 3-point immobilization. At that point of time, you shouldn't be forcing the patient. Forcefully application of an C-collar and 3-point immobilization causes more harm than any protection. For that reason, the recommendation is do not force anyone. You need to explain them what you're doing it. If they're cooperative enough, then you go ahead and place the 3-point immobilization. Now we are talking about airway management that comes in between here. First is manual inline stabilization, then comes the airway management. While looking at the airway, you look, listen, and feel. What are you looking out for? Look out for the face. Are there any obvious serious injuries on the face which causes facial deformity? Listen for breath sounds, especially any abnormal breath sounds are present, like an stridor is present. That is important to look. Any stridor is present. Any gurgling sound is present. Any grunting is present. It is important to see any grunting, any stridor, any gurgling, any snoring is present. These are the 4 terms what you'll be looking out for. It is highly suggestive of an upper airway obstruction. So look out for these 4 things in the stem of the question. Then you will be feeling for the movement of the air. Is this patient really breathing or not? Feel for the movement of the air. So look, listen, and feel. In listen, you're listening for any stridor, gurgling, grunting, or snoring is present. Then what do you think? If nothing is present here, you will connect to the high flow oxygen, move ahead with the breathing. No, there is some stridor is present, some gurgling. So some added sound is present. If some added sound is present, you will open the mouth, visualize inside the mouth, and look for if there any secretions are present. If present, you will suction it out. Look for if any foreign body is present. If present, you will remove the foreign body using an forceps under direct vision. Okay, under direct vision is very important. You shouldn't blindly just suction it, or you should blindly shouldn't put any forceps and try to remove it. That is a wrong method. You need to visualize it. Once you visualize a foreign body, then only you're attempting to remove it. If you're not visualizing, you're not attempting to remove it. In children's, one more thing what you need to be aware of is the larynx is kind of funnel shape. So the secretions can get accumulated more in the posterior part, that is the retropharyngeal area, and it might be difficult to suction it out. Even the removal of a foreign body is much more difficult in a child compared to that of an adult. This is because of the anatomical variation in the child. Still, there was some secretion, you suction it out, but no secretions were there, but still persistent added sounds are present. That means we'll assume that still the stridor is present, or snoring is present, or grunting is present. If still it is present, what you will be doing? You will be performing simple airway maneuver. The preferred simple airway maneuver in a trauma case is an jaw thrust technique. What you need to do it? We do not prefer an head tilt chin lift technique, mainly because it causes movement of the cervical spine that might injure or worsen the cervical injury which is already present. So we are not aware by now this time. For that reason, you're always doing an jaw thrust technique. Once your jaw thrust technique is done, you will see whether the still added sounds are persistent or not. If it is persistent, then advanced airway is required. If it is not persistent, then you cannot be holding like this for a very long time. So you need to place an simple airway devices. What are the simple airway devices which you can use it? Oropharyngeal airway or a nasopharyngeal airway, you need to place it. Oropharyngeal airway is measured from the angle of the mouth to the angle of the mandible. Then you're placing it. You can either go in a reverse manner till it is half and twist it around 120 degrees, 180 degrees, or the preferred method in the 10th edition of the ATLS, what they have recommended is use a tongue depressor and go directly in the same manner. Do not flip it around, just go directly and place it. The main thing, the change has come across is there was a lot of soft tissue injury was reported because of this method. That's why they have changed it, and they have preferred to do it with a tongue depressor and directly placing it and not flipping it by 180 degrees. Next is nasopharyngeal airway. Nasopharyngeal airway is from the lateral part of the ala to the tragus of the ear, what you're measuring. That is the ideal size for that particular patient. Then you're placing it. Usually you start placing on the right nostril first because it is designed to be placed on the right nostril. You will be going with a to and fro movement. Before you're inserting, it is advised that you use some jelly. It can be a KY jelly or it can be a lidocaine. It's just to lubricate what you're doing. If you're not able to place in the right nostril because, for example, it was a deviated nasal septum, then you can place it on the left nostril also. You can try to place it on the left side in the left nostril also. This has few contraindications. What are the contraindications for an NPA? The main contraindication, what you need to remember is if you're suspecting a base of skull fracture, it is an absolute contraindication. You'll be suspecting a base of skull fracture if there is any clear fluid which is coming from the nose. Rhinorrhea is present, clear fluid is present. or there is an hemotympanum, that is blood on the tympanic membrane is present, or raccoon eye is present, then it is contraindicated. Do not place a nasopharyngeal airway. Another thing you need to remember here is whenever you place an oropharyngeal airway, it stimulates your posterior part of the pharynx. So gag reflex is stimulated. Okay, if the patient is able to tolerate oropharyngeal airway, that means the gag reflex is absent. If the gag reflex is absent, you can assume the GCS is less than 9, and this patient will be requiring an definitive airway, that is an intubation will be required. Involve the anesthetics as soon as possible. So if he is able to tolerate oropharyngeal airway, involve the anesthetic because you want to secure this airway. The GCS indirectly indicates that it is on the lower side. If the patient is not able to tolerate oropharyngeal airway, that means the gag reflex is intact. At that point of time, nasopharyngeal airway comes in and that is preferred. So always you will try to place an oropharyngeal airway. If the patient is not tolerating, that's when you go ahead and place a nasopharyngeal airway. Before that, always assess the patient, look for any base of skull fractures are there. If there are no base of skull fractures are there, then you're going ahead and placing it. To summarize everything, the first step in the airway assessment and management is look, listen, feel. If there is some abnormality, then you'll open the airway, remove any foreign bodies, and suction it out. Next thing is, this is what suctioning it out. Is improvement is seen, still no improvement is seen after suctioning it out or removing the foreign body, then you'll be performing simple airway maneuvers. While performing the simple airway maneuvers like a jaw thrust technique, what is shown here, if there is improvement, then you will go ahead with an oropharyngeal airway. If not tolerating, a nasopharyngeal airway. If there is no improvement with an jaw thrust technique, that's when you think of an definitive airway and go ahead with an definitive airway. A difficult airway trolley must be available at that point of time. This is nothing but head tilt chin lift maneuver. Many people get confused. Head tilt chin lift maneuver, you can see the mouth is not open. Jaw thrust technique, you can see the mouth is not open. Okay, so mouth open and suctioning is completely different from simple airway maneuvers. Simple airway maneuvers is required to open the airway, not the mouth. Okay, there is a difference between opening the airway and opening the mouth. Opening the mouth is totally different from opening the airway. Do not get confused. That is the airway management what we are dealt with. If there are no respiratory efforts at all, at that point of time, you need to push the air inside the patients. That's when the back mask ventilation comes in. If there are no respiratory efforts at all, that means the patient is in respiratory arrest. You need to push the air in with some pressure needs to be pushed. That's why you need an bag mask ventilation, like an ambu bag, what you need to use it. Or in water circuit, you can use it at that point of time. Little bit below, we are getting into the neck there where larynx is present. Larynx in a trauma patient. Okay, this is only applicable to a trauma patient. If a traumatic patient comes to the emergency department, injury sustained to the neck and has an hardness of voice, you need to think of laryngeal fracture. Has subcutaneous emphysema in the neck. When you palpate, there are crabs, what you can feel it on the neck. You need to think of a laryngeal fracture. If there is a palpable fracture, that means, what do I mean by palpable fracture? Is step deformity is present. If step deformity is present on palpation, you need to suspect a laryngeal fracture. If you are suspecting a laryngeal fracture, you need to immediately secure the airway because swelling can develop and it can compromise the airway. Once the swelling develops, it becomes very difficult to secure the airway. You might have to go ahead with a front of neck access, which is difficult to do it if there is a swelling in the neck. That's why before the swelling develops and compromises the airway, go ahead and intubate this patient if any of these signs are present because it is suggestive of an laryngeal fracture previously tested. Now we are getting into more into the chest now. That is basically we are dealing with the breathing. Airway is finished. We are going come down into the lungs. That is the breathing what we are looking at. Airway obstructions we are already dealt with. What are the important factors what you need to really look out for in the primary survey when you're checking for the breathing? Is the patient is in tension pneumothorax, open pneumothorax, massive hemothorax? So team massive hemothorax, what I'm talking about. These are the three things, important things what you need to look out for. Next one is the flail chest. Flail chest is kind of replaced by tracheobronchial injuries nowadays, followed by cardiac tamponade. This can be easily remembered with a mnemonic known as ATOM FC. Use this mnemonic to remember. Okay, these are the life-threatening chest injuries. You shouldn't miss it, or you should be able to pick it up in an primary survey. First thing what we are seeing is a tension pneumothorax. First, let us see what is pneumothorax. Pneumothorax is accumulation of the air inside the pleural space. Whenever there is an accumulation of the air inside the pleural space, then you call it as an pneumothorax. Okay, it doesn't mean it is an tension pneumothorax. When do we call it as a tension pneumothorax? If a patient has a pneumothorax, it can be any pneumothorax. It can be a traumatic pneumothorax, a simple pneumothorax, or it might be an primary simple pneumothorax or spontaneous pneumothorax. But any pneumothorax can be a tension pneumothorax if the patient is unstable. When do we call it as a patient is unstable? If the systolic blood pressure is less than 90. If the systolic blood pressure is less than 90, along with the patient has a pneumothorax, you label this pneumothorax as a tension pneumothorax. You do not depend on the radiologist to tell you that it is a tension pneumothorax. No, it is a clinical diagnosis of a tension pneumothorax. There is no role of radiologist. They shouldn't be commenting whether this pneumothorax is a tension pneumothorax or not. That is absolutely wrong. A radiologist do not have anything in the X-ray to really label it as yes, it is a tension pneumothorax, or no, it is not a tension pneumothorax. They are not the persons. You as a physician, they should be able to clinically diagnose whether it is a tension pneumothorax or not. In an tension pneumothorax, it doesn't mean what we have described. All these signs and symptoms should be present. May not be present. Few of them might be present. Few of them may not be present. The important one should be present to call it as a tension pneumothorax is then hypotension. In a trauma, there is obviously a chest injury which is leading to an tension pneumothorax. That's why you will be having chest pain. Obvious it is. Because the air is getting accumulated in the pleural space, you can see the air is getting accumulated in the pleural space. The lung parenchyma gets under pressure and it gets pushed in. It cannot expand at all. If it is not expanding, it is not participating in ventilation. If it is not participating in the ventilation, the patient becomes hypoxic. Because of hypoxia, the patient starts breathing fast. He becomes tachypneic. Because the air is getting accumulated in the pleural space, the pressure in the thorax increases. So the intrathoracic pressure significantly increases. Once this intrathoracic pressure significantly increases, it obstructs the venous backflow, especially from the neck, it obstructs it. That's why you see an raised JVP or distended neck vessels in the neck, what you'll be seeing. At the same point of time, the blood which is coming from an inferior vena cava also gets hampered. That means it cannot come in because there is a lot of pressure is there. Usually the flow is from high pressure to the low pressure. Here the pressure is much lower compared to here. So it cannot go in the reverse manner from a low pressure to a high pressure. It cannot go in that manner. So the venous return will decrease. If venous return decreases, that means there is a decrease in preload. If there is a decrease in preload, that means there will be decrease in cardiac output, resulting in low blood pressure. That's why hypotension is at most important for you to call it as a tension pneumothorax. Sometimes there might be a surgical emphysema when you palpate the chest. Trachea might be deviated to the opposite side. It is a very late sign when I tell the trachea is deviated to the opposite side. So if the pneumothorax is on the left, for example, this is on the right side, it will be deviated to the left side. It is a late sign. Do not look for the tracheal deviation in the X-ray to call it as a tension pneumothorax. That doesn't tell you whether it's a tension pneumothorax or not. The trachea might be central and the patient might be in tension pneumothorax. On examination, on the injured side, the air entry will be reduced, the chest expansion will be reduced, and on percussion, this is important, on percussion, the patient will have hyperresonance. This is very important. On percussion, hyperresonance is very important because this is the first sign which develops in an tension pneumothorax or in a pneumothorax itself. Hyperresonance in on the chest is highly suggestive of a pneumothorax, and it is the first one to appear. So have a closer look if they mention hyperresonance in the stem of the question, or they might ask you which one of the signs is the first to appear. It is the hyperresonance. Sometimes in a trauma case, for example, it's a traumatic arrest, how to make out it is a pneumothorax or not. Getting an X-ray done is not very sensitive. Ultrasound is very sensitive compared to an X-ray. What you can do is you can just place and probe, abdominal probe, that is curvilinear probe over the chest, place it, use an M mode. In M mode, if you place it, if the lung is normal, this is the appearance what you'll be getting. This is known as seashore sign. What is seashore sign? This is supposed to look like an sand and this is supposed to look like an water. It is as if you are sitting at the seashore and looking at the sea. So this is a sand and this is the water. It's supposed to look in that manner. This difference will be lost if there is an pneumothorax. So this difference is lost during the pneumothorax. This appears like an barcode. If you go to any grocery shop and pick up a pack of a biscuit or anything grocery item, you will have a barcode. It appears very much similar to the barcode which is placed in an vertical manner. That's why it is known as barcode sign. A barcode sign. Presence of a barcode sign is highly suggestive of a pneumothorax. You need not even get an X-ray done. This should be sufficient to label the patient as having an pneumothorax. So it is important. Similar images can be given in the exam and ask you to pick it up. So remember how an barcode sign appears. It is important from exam point of view. There is one more sign which can be seen on an ultrasound scan. That is absence of lung slide. Absence of lung slide. This can be seen only in a dynamic image. So they can give an wording of absence of lung slide, but they cannot give you an image because it has to be a dynamic image. Then only you can appreciate whether lung slide is present or an absent. That's why remember the wordings, that is important. Image is not required from exam point of view. So it is intention pneumothorax. You have made the diagnosis of intention pneumothorax. How do you manage it? Manage is first thing always comes an airway. If the patient has a tension pneumothorax and compromised airway, secure the airway. That should be done first. After that, you are entering into the breathing. In breathing comes the tension pneumothorax. Then you will be dealing with the tension pneumothorax in the breathing. In the breathing, what you'll be doing, the first step is to do a finger thoracotomy. Finger thoracotomy is preferred over needle decompression. If you cannot do an finger thoracotomy or it is not mentioned in the options, then you can go ahead and do a needle decompression. Once needle decompression is done, a tension pneumothorax will be converted into a simple pneumothorax. Once it's converted into a simple pneumothorax, place an chest tube. For a simple pneumothorax, the treatment is placement of an intercostal drain. That is, a chest tube needs to be inserted. After that, call cardiothoracic surgeons and let them know this has what has happened, because they might want to intervene at a later stage. Immediately, they might not intervene. A later stage might be required, but you need to always involve the cardiothoracic surgeon as a third step. Way to do a needle compression is important. According to the 10th edition of ATLS, they have changed the position of where you used to do, it has changed. Now they recommend it to do it just anterior to the mid-axillary line in the 5th intercostal space. Important, remember this because this has changed in the 10th edition. In 9th edition, it was different. 10th edition, they have changed it to this one. This is what you need to remember. Just anterior to the mid-axillary line in the 5th intercostal space. In the pediatric age group, it is mid-clavicular line, second intercostal space. It changes in the pediatric age group. Pleural aspiration. Pleural aspiration is different from needle decompression. Both are not the same. We will be discussing about this in the respiratory chapter. Remember here that pleural aspiration is done in mid-clavicular line in the second intercostal space in both adult as well as in the pediatric age group. This is different. Do not get confused with this one. For that purpose, I have mentioned it all together so that you are already aware of the difference. And when I mention in the respiratory chapter, you know I'm talking about pleural aspiration here. I'm not talking about the needle decompression. Open pneumothorax. What is open pneumothorax? Open means there is an open wound which is present over the chest. Because of the presence of this open wound, depends on how big is the open wound. If the size of the open wound, the diameter of the size of the open wound is more than or equal to 2/3 of the trachea of that patient, then air will start moving preferentially through that wound rather than through your mouth and through the trachea of that patient. So once the air starts entering through that wound, you will start hearing and sucking a bubbling sound through the chest wound. That is important. So you need to look out for in the stem of the question, is there any bubbling or sucking sound which has been mentioned? If mentioned, that means the diameter of that wound is more than 2/3 of that of trachea. That's why the air is getting sucked in. If the air is getting sucked in, it is getting sucked in into the pleural space. Air is getting accumulated into the pleural space. That's why it is known as open pneumothorax. So when you get an X-ray done, X-ray will be in this manner. You may not be able to clearly appreciate because there is an open wound which is there. You may not be clearly able to appreciate the pneumothorax at all in this patient when you're looking at the chest X-ray at all. So there are multiple rift fractures might be there. There might be some associated associated subcutaneous emphysema can be present. Those parameters what you will be looking out for. If this open pneumothorax, the patient is unstable. When I say unstable, again, it is the systolic blood pressure being less than 90. Then you need to do an decompression. Finger thoracotomy is preferred. If that is not given in the options, then you're doing a needle decompression. Once you are done in needle decompression or the patient is stable, then you will do an occlusive dressing. Occlusive dressing should be a three-way dressing. So you need to leave one side open and three side you have occluded. Why you are occluding in this manner? To have an flutter effect, a flutter wall effect, what we call it. What is flutter wall effect, what you are having? Flutter wall effect is during inspiration, this dressing gets sucked in and it forms a good seal. So nothing comes inside it. Okay, it gets sucked in for that particular reason, or because it is getting sucked in, no air enters in. During expiration, it is blown out. There is a little bit opening comes up here and the air can escape out. Okay, never do an four-way dressing. Four-way dressing is four-way occlusive dressing. If you occlude of this side also, what will happen? If you occlude this side also, there is no way the air can escape. And a simple open pneumothorax, you might end up converting into an tension pneumothorax. Okay, so you need to be doubly careful. Don't do an four-way occlusive dressing. It should be only three-way occlusive dressing. If you do it and four-way occlusive dressing, chances of development of intention pneumothorax is high. Once you have done this dressing, you have converted an open pneumothorax into a simple pneumothorax. A simple pneumothorax treatment we are aware of, you need to place an ICD. So you need to place an chest tube. Can I place an chest tube directly inside the wound what is present? It is an open wound. Can I just place a tube inside it? No, absolutely not. It is contraindicated to place a tube inside it. Okay, so you should avoid that site and see the anatomically safe area where you can place it and you need to place it there. Why you shouldn't place in the wound? Because you are not aware what's the extent of the wound. How deep is the wound? Is it entering into the lung parenchyma? If it's so, when you place a tube and the tube will enter into the lung parenchyma, it's supposed to be only in the pleural space, not enter into the lung parenchyma. For that particular reason, you need to insert it on a different side, not at the same side. Eventually involve the cardiothoracic surgeons. Open wound might require a surgical closure. That call will be taken by the cardiothoracic surgeons. Massive hemothorax. When do we call it as an massive? Or what is hemothorax? Hemothorax is accumulation of the blood in the pleural space is known as hemothorax. Simple. When do we call it as a massive? You call it as a massive if the initial blood loss, that is after placing an ICD, you drain more than 1.5 liters. Or in the ICD, you see more than 200 ml every hourly, you are able to see the blood loss or blood is coming out from the ICD for continuously for 2 to 4 hours. Then you label it as a massive hemothorax. It is very important to pick up a massive hemothorax because if the patient is having a massive hemothorax, there is an ongoing bleeding what you need to suspect in the chest. So immediate cardiothoracic surgeon needs to be involved so that the bleeding can be stopped. If it is continuously profusely bleeding, then you clamp it so that a tampon effect happens here inside the lungs and the bleeding stops and you're suspecting an arterial bleed in the chest, what is happening. Okay, so for example, you have placed an ICD. After an half an hour, you're seeing the underwater seal has 2 liters of blood in it. A frank 2 liters bright color blood is present. Then immediately clamp it so that the you do not drain more blood and it has a tampon effect and stops the bleeding. Next thing is how to manage it. First thing, if airway is compromised, deal with the airway because airway comes before the breathing. In breathing comes the massive hemothorax. For the treatment for massive hemothorax is placing a chest tube. Okay, have a closer look. If more than 1.5 liters is drained, clamp it. Next thing is to involve the cardiothoracic surgeon. Sometimes intervention might be required, sometimes it might be conservative, depending on what kind of injury the patient is having. If it's an arterial bleed, then obvious cardiothoracic intervention will be required. If it is a venous bleed, it usually stops on itself. Nothing much is required to be done. Flail chest. When do we call it as a flail chest or foreign flail chest? What is the prerequisite? Two adjacent, for example, 1 and 2, two adjacent ribs should be fractured at two different sides. One side, this is one side, this is two side. Okay, this is one side, this is two side. two different sides so that it forms an segment. If an segment is formed by the two adjacent ribs which are fractured at two different sides, then it forms an flyal segment. This flyal segment will have paradoxical movements. What is paradoxical movements? During inspiration, when you are trying to suck the air in, it is drawn inwards. This segment is drawn inwards. Rest of the rib cage is drawn outwards. During expiration, this segment comes for pushed outwards. Rest of the chest comes inwards. That is, the rib cage comes inwards. So it is in the opposite direction the movements are going on. That's why we call it as in paradoxical movements can be seen. This itself will not cause an hypoxia. If the patient has an hypoxia because of an flail chest, you need to suspect that there is an underlying lung contusion which is present. If lung contusion is present, you need to always admit this patient. Admission is a must for an lung contusion. What is lung contusion, first of all? Lung contusion is nothing but it's capillaries which are leaking or oozing out. Capillaries have got injured. They are oozing out. Because of this oozing out, there is some blood accumulation. This is known as contusion. Over the time, there might be significant amount of blood which has oozed out and can cause compromise in the breathing. That might require immediate intervention. And these lung contusions can have a complication of an ARDS. So this patient needs to be admitted in a level 2 care. A level 2 care is a care where anesthetic backup is present. For that reason, a level 2 admission is a must because this patient can deteriorate at any point of time. At that point of time, intubation and mechanical ventilation will be required because they can undergo an ARDS as soon as in first 24 hours itself, they can develop an ARDS. So initially, you are admitting for observation. Later on, you might have to intervene. So level 2 care is important. What is the management of flail chest? Is the pain management is the preferred one, or pain management what you're supposed to do it? What kind of pain management you will be doing? Pain management, the best way to deal with the pain of a rib fracture is a rib fracture what you're having, basically a fracture, by giving a nerve block, an intercostal nerve block supposed to be given. We will be learning how to do it in the procedures. An intercostal nerve block which is required for the pain management that gives excellent pain management. On an X-ray, you might see a lung contusion like this. There might be some amount of subcutaneous emphysema, but it is very difficult to pick it up whether it is a flail chest or not. It is basically on inspection of the chest. When you expose the chest and you're inspecting the chest, at that point of time, if paradoxical movements are present, a flail chest can be picked up. So have a closer look for a paradoxical word in the stem of the question if you want to pick it up as a flail chest. Cardiac tamponade. Okay, any patient in a trauma case comes with a cardiac tamponade. The treatment of choice is thoracotomy. Okay, you need to remember a traumatic cardiac tamponade, thoracotomy, what you are supposed to do. Cardiac tamponade usually presents with a triad with a distended neck vessels, muffled heart sounds, and hypotension. Remember that in tension pneumothorax also you'll be seeing distended neck vessels and hypotension. Muffled heart sounds is the one which will help you to differentiate between a cardiac tamponade and that of the tension pneumothorax. Decreased air entry is seen in tension pneumothorax. Hyperresonance on percussion is seen in tension pneumothorax. So you need to remember how to differentiate it. There are two things, that is the distended neck vessels and hypotension overlaps that of the tension pneumothorax. Muffled heart sounds is not seen in tension pneumothorax. You need to be aware of. Get a quick EFAST done and look for the free fluid. This is the black color what you're seeing here is suggestive of a free fluid around the heart. That is nothing but fluid in the pericardial space. In a trauma case, you need to suspect this is the blood. And if you notice that there is collapse of the RA-RV during the diastole, it is labeled as cardiac tamponade. This is the EFAST finding, which will label it as a cardiac tamponade. You can see here closely that it is getting completely collapsed. This is getting completely collapsed during the diastole. What is the first step? Airway, you manage it. Definitive management for a cardiac tamponade, or the first step is basically doing a thoracotomy. If you are not qualified enough to do a thoracotomy, involve a cardiothoracic surgeon. What if you do not have a cardiothoracic surgeon? You are not capable of doing a thoracotomy and you do not have an equipment to do a thoracotomy. Then you can try to do a pericardiocentesis. Okay, pericardiocentesis can be done at that point of time. It is a temporary measure, but might be life-saving in this individual. So you do an pericardiocentesis and try to involve cardiothoracic surgeon as soon as possible. A shift to a center where cardiothoracic surgeon is available so that they can do an thoracotomy. So pericardiocentesis can be done. Why it is not preferred? It is not preferred because this is and bleed what is present here. Lots of clots will be there. If you start aspirating, you will might not be able to completely aspirate, or you might end up aspirating the clots and resulting in more and more bleeding, which can cause the death. But if there are no resources available, pericardiocentesis can be tried. Traumatic aortic disruption. What do I mean by disruption? So some injury to the aorta. It might be a complete dissection, or just in some oozing of the blood from the aorta might be present. It is very difficult to pick it up clinically in the sorry, it is very difficult to pick it up clinically in emergency department. The definitive diagnosis, if you want it, you need to get an aortogram done. So aortogram needs to be done to definitely CT aortogram I'm talking about, to definitely label this patient has an aortic disruption. But you can guess it with the history what you're collecting and with the X-ray findings, you can guess it. Okay, if there is a blunt deceleration trauma, what do I mean by deceleration trauma? For example, you are driving a car and you have the seat belt on. Suddenly you brake or suddenly you bang and wall. You will go forward or move forward, and suddenly the seat belt will hold you and pull you backwards. It's holding and pulling you backwards is the deceleration trauma what you are having. Okay. A fall from the height also will have the similar mechanism, will result in deceleration trauma. Whenever there is a deceleration trauma, you can suspect there might be an aortic disruption. Plus, what you'll be doing clinically, get an X-ray done. In X-ray, what you'll be seeing? In X-ray, there will be widening of the mediastinum. Widening of the mediastinum 90% of the time is not because of aortic disruption. It's because of the oozing of the blood from the minor vessels which are present in the mediastinum. But aortic disruption is the first thing should come in your mind, because that is a life-threatening. The patient can die if you miss it. Along with it, there can be an left-sided pleural effusion. Trachea will be pushed towards the right side. You can see this is the trachea which is pushed towards the right side. Left-sided pleural effusion, everything is wide out on the left side. What do you need to pick it up? Loss of aortic knuckle can be seen, but it is very difficult to pick it up on this X-ray. Along with it, you might see a first rib or a second rib or a scapular fracture. First rib, second rib, or a scapular fracture, if at all, if you present, you need to always suspect the intensity or the mechanism of injury is very bad. It is a high impact injury or high energy injury the patient had. You need to suspect some serious injuries if there is an associated first rib, second rib, or an scapular fracture is present. Airway should always be dealt with, because aortic disruption is in the thorax, is in the breathing, what you are doing it. So airway and breathing, you are dealing or giving resuscitation. Basically, you cannot do much about the aortic disruptions. If the patient is hypotensive, you'll be resuscitating the fluid and the blood products. Involve the cardiothoracic surgeon. Only cardiothoracic surgeon can save you here. You cannot do much as in definitive management for aortic disruption in the emergency department. Little bit below, if you come, you have a diaphragmatic rupture can be present. How to pick up a diaphragmatic rupture? Whenever there is a rupture of the diaphragm, bowel loops will enter into the intrathoracic space. You can see here in intrathoracic space, bowel loops are entered in. Intrathoracic space, bowel loops are entered in. What precautions needs to be taken if there is a diaphragmatic rupture? If there is a diaphragmatic rupture, when you are intubating, do not do an bag mask ventilation. Do not bag the patient. Why you shouldn't bag it? Because the air can enter into the bowel loops and cause distension and cause more compromise of the lungs. Okay, because they are intrathoracic. So bag mask ventilation is not advised. Placing a nasogastric tube is also not advised, because it can come in, it can loop around and cause perforation of the bowel. It can be a disastrous. So nasogastric tube and before intubation, doing and bag mask ventilation is kind of needs to be prevented. Definitive management only can be done by cardiothoracic surgeon. So involve the cardiothoracic surgeons. There is one more thing. Usually when they give this kind of x-rays, usually a term will be mentioned. This is known as Chilaiditi syndrome. What does this mean? This is a medical condition where, if this is the diaphragm, what you're seeing it, this is the left-sided diaphragm, what you are having it. In between the diaphragm and the liver, what you are having, bowel loops are present. Bowel loops are present. This is known as Chilaiditi syndrome. This bowel loops, what you're seeing, is because of the Chilaiditi syndrome. But whenever there is an trauma involved, always think of an diaphragmatic herniation. Diaphragmatic rupture, what do you need to think? Because of diaphragmatic rupture, there is a herniation of the bowel loops inside the intrathoracic space. What do you need to suspect or what do you need to think of? Blunt myocardial injuries. So a blunt injury to the chest can result in injury to the myocardial muscle. How do you suspect it? Get an ECG done. There are no specific changes on the ECG which will indicate directly that this patient is having a myocardial injury. You can just suspect it. How do you suspect it? If any changes in the ECGs which are present, which were not present previously for that patient, it's a new change on an ECG. Anything abnormal which you see, which is new for that patient on the ECG, then you need to admit that patient. Okay, you will admit that patient for a cardiac monitoring for minimum of 24 hours. Why do we admit? Because any injury to the myocardial muscle can trigger arrhythmias, which can be and disastrous. That's why you need to admit this patient for 24 hours. You need to admit this patient to make sure this patient doesn't develop arrhythmias. If develops, you can intervene immediately. So cardiac monitoring is required for 24 hours. That is why you are admitting this patient. Esophageal rupture. Esophageal rupture, it might be because of a direct penetrating trauma. Is a direct penetrating trauma to the esophagus can result in esophageal rupture. It is an easy thing. Another thing is if there is a blunt injury to the upper part of the abdomen, and the stomach is full. So stomach is full. You just had a meal, involved in a road traffic accident, and there is a blunt injury to the upper abdomen. A blunt injury to the upper abdomen will cause reflex of the foot into the esophagus. This reflex of the foot will cause immediate increase in esophageal pressure and can cause distension and rupture. This is one of the commonest mechanism of injury which causes an esophageal rupture. Surgical emphysema can be present because esophagus has some amount of air in it, and pneumomediastinum can be seen because it is a structure of a mediastinum. So it is a mediastinal structure. Air is there, air leaking out, pneumomediastinum and surgical emphysema can be seen. Along with it, the esophagus has food particles. These are unsterile. If they get spilled out in the mediastinum, it can cause severe infection, even death. Most of the time, the death is because of the infection, not because of the esophageal rupture. For that reason, the first step in management of an esophageal rupture is to give antibiotics. The second step is to involve cardiothoracic surgeons. Tracheobronchial injuries is very difficult to pick it up clinically in the emergency department. Okay, they can present it in various ways, like there might be an hemoptysis, subcutaneous emphysema, attention pneumothorax. But how to know whether there is an underlying tracheobronchial injury? You can suspect it if there is continuous air leak in the chest drain. So you have an underwater seal which is present here. Okay, you have put an chest drain. You come back after 1 hour, still there is bubbling which can be seen here, significant amount of bubbling which can be seen. So significant of air leak which is happening continuously. That should alarm you thinking of there might be an tracheobronchial injury. Definitive diagnosis only can be done by bronchoscopy. Repair needs to be done by cardiothoracic surgeon. So definitive treatment is always done by cardiothoracic surgeon. Confirmed diagnosis by bronchoscopy. A persistent air leak after chest drain insertion should raise the suspicion of tracheobronchial injury. Sternal fractures. Whenever the sternum is fractured, high impact energy is there. This is a bad mechanism of injury. What you need to suspect. Suspect myocardial contusion might be present, or any injuries to the greater vessels you need to suspect. Same thing holds good for the first and the second rib fractures. So summarize when do you involve the cardiothoracic surgeon? If there is a massive hemothorax. By definition, massive hemothorax is loss of more than 1.5 liters of blood or more than 200 ml in consecutive 2 to 3 hours or 4 hours. Then you call it as a massive hemothorax. You need to involve the cardiothoracic surgeon. Almost all penetrating chest injuries eventually will require an cardiothoracic surgeon. Cardiac tamponade for thoracotomy, cardiothoracic surgeon is required. When you are suspecting an tracheobrachial injury, when there is a persistent air leak, you need to involve the cardiothoracic surgeons. Esophageal injuries, only they can repair it. Again, you need to involve the cardiothoracic surgeons. Before I enter into the circulation, let me take a few questions what you have been having. Sorry, fluid on cardiac tamponade is about 100 ml. what's the best and when we prefer thoracotomy rather than pericardiocentesis? Thoracotomy is the preferred one. Okay, it is always thoracotomy. Okay, it's not that dependent on the fluid what you are having in the pericardial space. Doesn't matter. It might be 1 ml what you're having. If it's a cardiac tamponade, what you're having it. It's a thoracotomy you're supposed to do it, not pericardial synthesis. If thoracotomy cannot be done because you're incompetent to do an thoracotomy, you do not have an instruments to do an thoracotomy, or if you do not have cardiothoracic surgeon available in your department, at that point of time, you are trying an pericardial synthesis to save the life. Ideally, thoracotomy needs to be done. All right, this was the only one question. There's no other questions. Let me again see any other questions. Okay, we enter into the circulation part. So we have dealt with airway. We have dealt with breathing. Airway and breathing has been done. We are into the circulation part. In circulation, we'll be checking heart rate, blood pressure, capillary refilling time, and peripheral pulses. Get two large IV bore cannula at two different sites, ideally at two different limbs. Send investigations which should involve blood group and cross matching, which is important, along with the coagulation profile needs to be sent for. A adjunct which is used in circulation is the e-fast. You shouldn't be forgetting to do an e-fast. So how do we manage if there is some hemodynamic compromise, if the patient is unstable, how do we manage the patient in circulation? In the first step is stop the source of bleeding. If there is an obvious bleeding which is there, stop it. How to stop it? We take an example that there is an arterial bleed. There is a spurting of the blood from the mid-thigh, right mid-thigh, it is spurting. What you will be doing first? The first thing you will be doing is, can you visualize the bleeding artery? Bleeding artery can be seen or not. If you can see the bleeding artery or the culprit vessel, it can be a vein and an artery. If you can see it, clamp it. So this is the best way to stop it. Most of the time, that means 90 to 95% of the time, you will not be able to see the bleeding artery or the clamp because there would have been so much amount of blood. It is a pool of blood what you will be seeing it. At that point of time, apply direct pressure. If direct pressure is usually using an gauze using a pad, place and pad, apply and direct pressure using your hands. If that doesn't stop bleeding, then do an compression dressing. Hemostatic dressings are also available. If available in your emergency department, you can use it. If not available, compression dressing is the preferred one. What is compression dressing? We will imagine this as an, sorry. Okay. We will imagine this as an wound and this is the limb what you are having it. Okay. So you take and roller gauze. Take and roller gauze, roll it up, make it hard as is possible. Place the roller gauze over the wound what you are having it. Then roller gauze you have. Then open the roller gauze another one and roll it across it. In this manner, the maximum pressure will be over the wound. This is known as compression dressing or an pressure dressing. This is important, works excellently in most of the settings. Use it if you do not have hemostatic dressings. Hemostatic dressings are expensive also. If you cannot afford it, use compression dressings. They excellently work. If this also doesn't stop the bleeding, proximal to the wound, you're placing an tourniquet. If this also doesn't stop bleeding, one more tourniquet is placed proximal to it. If this also doesn't stop bleeding, you directly apply the pressure over the major artery. For example, in the lower limb, the major artery will be the femoral artery. Apply directly, compress the femoral artery to stop the bleeding. Stopping the bleeding should take the priority over fluid or the blood resuscitation. Most of the time, blood will not be available in the emergency department. For that reason, you start resuscitating with the fluids. It's not that the fluid is better than the blood. Blood is the best fluid what you can do for resuscitation in an hemorrhagic shock. Because hemorrhagic shock is because of the blood loss, you're replacing the blood. So that is the ideal way to deal with it. But most of the time you do not have the blood. Blood is not stored in the emergency department. It is stored in the blood bank. By the time the blood comes from the blood bank, it takes few minutes. For that reason, start with crystalloid fluids. The preferred one is ringer lactate or the Hartmann's fluid, what you'll be using. Once you start resuscitating with the Hartmann's fluid, once the blood products are available, you start resuscitating with the blood products. Involve the surgeons or the vascular surgeons, depending on what kind of blood loss it is and where the blood loss it is. The fifth step is to give the tranexamic acid if they are presented within 3 hours of the injury. After 3 hours, it is not recommended because it is kind of useless after 3 hours. Within 3 hours, they are presented of the injury. Then you can give tranexamic acid as soon as possible, 1 gram bolus, followed by infusion of 1 gram over 8 hours of time. Over 8 hours, infusion you are giving it. How to resuscitate the patient? Blood and blood products and fluids, how to give it. As we know that first we are starting with IV fluids because blood is not available in the emergency department. You give a small bolus, for example, of 500 ml of IV fluid you are given. See the response. If there is a rapid response, all the vital parameters are come back to the normal. That means you are thinking the blood loss is quite minimum, that is less than 15%, equals to 750 ml. So in this patients, if at all, if you want to do an blood transfusion, make sure it is a type crossed and cross matched and type specific blood transfusion what you're doing it. So for example, if it is A positive, you're giving an A positive blood itself, which is cross matched, then you're giving it. There was a transient response. So you give IV fluids, the blood pressure picked up and came up to around 95. Then again, it fell down to 85. That means there was a transient increase in the blood pressure. If there is a transient increase in the blood pressure, that means you have enough time to give and type specific. That means if it's A positive, give A positive. Type specific blood itself, you have enough time to wait for type specific blood to be given for that patient. Cross match, you may not have enough time to do and cross matching. If there is only minimal response or no response to the fluid resuscitation what you have done, then immediately transfuse blood whichever is available. That means O positive blood or an O negative blood can be transfused. O negative blood is the preferred one. So if O negative blood can be or should be immediately transfused, this can be a life-saving procedure. When you are transfusing or when you are resuscitating the patient who is hypotensive, your target blood pressure should be always 90. Systolic blood pressure should be 90 or around 90. Exactly 90, no one can make it. Around 90, what is targeted? More than 90 is not preferred. Why is it not preferred more than 90? In a healthy individual, I'm talking about, why is it not preferred more than 90? If it is more than 90, if a clot has been formed over an artery, this can get dislodged because of the increase in the systolic blood pressure. We do not want this to happen because the rebleeding can occur. For that particular reason, the targeted blood pressure is the 90. Classification of hemorrhages. So how do you classify? You can guess how much amount of blood or the what percentage of the blood loss is there in a patient who had a trauma by looking at the vital parameters. If the blood loss is around 15, less than 15%, that means less than 750 ml if it is present, all the parameters, the vital parameters will be within the normal limits. If it is somewhere between 750 to 1500 ml blood loss is present, at that point of time, pulse pressure comes down. What is pulse pressure? Pulse pressure is systolic blood pressure minus diastolic blood pressure is known as pulse pressure. Initially, there will be increase in sympathetic tone resulting in increasing in diastolic blood pressure. Increasing in diastolic blood pressure will narrow down this pulse pressure. Pulse pressure normally is between 40 to 60. It will come down. It will narrow down. That is the first feature. Tachycardia might be present, may not be present. Between 1.5 to 2 liters of blood loss, that is 31 to 40% of the blood loss is present. That's when you start actually seeing tachycardia in those patients. Blood pressure might be in the normal side or might start falling down. Pulse pressure obviously will be on the lower side. There might be some tachycardia, reduction in urine output, a Glasgow coma scale. That means altered sensorium might be present at that point of time. So remember that if the blood pressure has fallen down, there is a minimum loss of 1.5 liters of intravascular fluid. That's when the blood pressure falls down. If there is more than 2 liters of blood loss, everything goes haphazard at that point of time. That's why a patient having a tachycardia shouldn't be taken lightly. The blood pressure might be on the lower side, but if the patient has a tachycardia, minimum of 750 ml, minimum I'm talking about, he has lost it. These features might be hampered depending on the medications what is taking. For example, a beta blocker, you might not see the tachycardia at all in that patient. So you need to be aware and apply it to a particular patient. What we're talking about is for a healthy individual. If there are some drugs he is taking it that can mask the vital parameters what you're seeing. So you may not see tachycardia at all, even though he has lost more than 2 liters of fluid in that particular patient. So be aware of this differences. It is very important. What are the indications for laparotomy? If it is a blunt injury, The patient should have an hypotension, and on fast scan, you should be able to show free fluid is present. You have done a fast scan. If it is positive, that means free fluid is present. In a trauma case, you need to always consider this fluid should to be the blood. If fast is positive and the patient is hypertensive, then you will you will involve the surgeons, and this patient requires immediate laparotomy. Peritonitis. What is peritonitis? If the patient is having guarding or rigidity, if any of this following is present, you need to suspect peritonitis. That is an indication in a blunt trauma for a laparotomy. Air under the diaphragm, air under the diaphragm. Always look at the right diaphragm. So the air is accumulated between the liver and the diaphragm. This is air under the diaphragm. If present air under the diaphragm, that indicates that there is perforated bowel. If perforated bowel is present, that is an indication for laparotomy. Visceral injuries on the CT scan. You got a CT scan, there is obvious visceral injuries are there, then you'll be involving, might or may not require laparotomy, depending on what kind of injury is there. Penetrating injuries. Penetrating injuries, if the patient is hypotensive, that is enough. You need not do a fast scan at all. Fast scan is not required because it's a direct penetrating injury in the abdomen. It requires a laparotomy because the patient is hypotensive. If the internal organs are oozing out, that is also an indication for laparotomy. If there is a bleeding from the orifices, that is bleeding from the mouth or bleeding from the mouth in the sense he is vomiting blood, hematemesis is present, or there is a PR bleed, hematochezia is present. What does it indicate? There is some injury to the bowel loops. Because there is some injury to the bowel loops, blood has accumulated in the bowel loops and it has gone down into the anus and come out to the gone down to the rectum and has come out through the anus. Or sometimes you might reflex it out. For example, the injury is in the stomach, you can vomit out the blood what is present. That's why if the bleeding from the orifices is present, you need to suspect GI tract injury. A gunshot with a trajectory. Trajectory means a pathway. This is a bullet which has passed through this here. So this is known as trajectory. It is not just stuck here in the abdominal abdominal muscles itself. It has entered into the peritoneal cavity and it has a path. If it has a path, a surgery needs to be done. What are the common structures which can get injured? For example, in blunt injury, spleen is which is commonly injured. Penetrating injury, liver is commonly injured. Gunshot injury, small intestine which is commonly injured. Abdominal organ injuries, specific injuries, and specific management for it. Splenic or hepatic injury, if the patient is stable, conservative. If the patient is unstable, you can see any abdominal organ injury, it is an operative, and operative injuries what you'll be having. If it is a renal trauma, in renal trauma, if unstable, again, operative. If the renal trauma is present, you're suspecting renal trauma because the patient is having a hematuria, which is visible to your eye, is known as macroscopic hematuria, then imaging will be required. That is CT KUB needs to be done. Depending on the findings, you need to inform the urologist, they will take a call. If it is a microscopic hematuria, only on the dipstick you are able to make out RBCs are present in the urine, then conservative management can be done. After a week, you will be repeating the urine dipstick in this individual. Then you will take a call what next to be done, depending on the opinion from the urologist, if it is still having a microscopic hematuria. Hollow viscous injuries, you are suspecting if there is a blood in the PR examination. Abdominal wall bruising from the seat belt. Seat belt is the abdominal seat belt, the horizontal seat belt which is present. Because of the seat belt, if there is a bruising present, that is an indication to go ahead and get a CT scan done if the patient is stable. If there is a lumbar fracture, if you're suspecting, get a complete CT scan of the abdomen because you need to suspect abdominal organ injuries. If there is a bleeding from the PR and the patient is stable, get an IV contrast CT abdomen done. So CT imaging is required in all this individual. Depending on the CT imaging, you will take a call whether to need to intervene or not to intervene. Bladder traumas. If the bladder is intraperitoneal, that means bladder is full and it has full and it has come into a peritoneal space, not in the pelvic space, it is in the peritoneal space, then operative surgery is required. If the bladder was empty and the bladder was in the pelvis and it has caused bladder rupture or bladder injury, catheter drainage should be sufficient. You keep it for a few days, it heals well. Intraperitoneal, that is if the bladder was full and it has ruptured, operative surgery, we call it because the urine would have spilled into the peritoneal space that is causing peritonitis can happen. That's why a wash is required and reconstruction of the bladder might be required. That's why you need to involve the urologist and the general surgeon. Urethral trauma. You're suspecting an urethral trauma if there is a blood or bruising over the urethral meatus. If present, you need to suspect an urethral injury. On examination, in PR examination, in and men, if there is a high rating prostate, also you need to suspect an urethral injury. Whenever you are suspecting an urethral injury, you need to refer to the urologist. This is different from that of the ATLS. ATLS suggests do an retrograde urethrogram. You're not doing an retrograde urethrogram. You're referring to the urologist because in NHS, sometimes urologists will come and try try once inserting an Foley's catheter. If it is successful, they can just leave it. No surgery will be required. After a month, it will heal on itself. Then you can remove it. Nothing needs to be done. Surgery can be prevented. That's why urologists usually like to get an Foley's catheter trial done for these individuals before going to an retrograde urethrogram. Okay, you yourself is not trying to place an urinary catheter in this individual. It is a contraindication for an emergency physician to place an urinary catheter if there is blood or bruising around the urethral meatus. Okay, or high rating prostate in a man. Any testicular trauma, if present, a ultrasound of the testis, the scrotum needs to be done. Because if it is just an scrotal hematoma, it can be managed conservatively. If it is a testicular rupture, operative management is required. That's why you will be getting an ultrasound scan done. Now we are coming below into the pelvis, a pelvic fracture. A pelvic fracture can result in enough blood loss to cause hemodynamic instability, especially if it is an open book fracture. Open book fracture, you're suspecting if there is a compression from the anterior and the posterior side. Someone is compressing. If this is the man who is standing, if there is a compression from both sides, anterior and posterior compressions are present, that will resulting in an open book fracture. What is open book fracture? Pubic symphysis will be significantly away from each other. Okay, this is known as open book fracture. It causes significant amount of hemodynamic instability in this patient. It can be because of fall from the height, direct crush injuries, or in pedestrian head by a car. Lateral compressions, lateral impact is there. Okay, side impact is there. This is unlikely to cause hemodynamic instability, unlikely to cause life-threatening hemorrhages here in this individual. Vertical shear is present. Vertical shear. So basically, you have fallen down from an height, fall from an height, vertical shear, it causes major instability. You can see this is in normal. This is pulled downward. Sorry, this is in the normal position. This is in the normal position. This one is gone upwards because you landed on your foot. It might be the left foot he is landed on. That's why the impact due to the energy, it has gone upwards. It's a vertical shear fracture, what we call it. This is highly unstable, can cause major bleeding in these individuals. Complex pattern, multiple, the pelvic system shattered. It is in high energy injuries. There will be major bleeding, obviously, in those individuals. Only the lateral compression doesn't cause hemodynamic compression. Lateral compression doesn't cause dynamic compromise. Anterior, posterior, or a vertical shear, or an complex pattern fracture, or combined fractures usually will cause major instability. How do you manage these individuals? So airway and breathing you have dealt with. Now you are in circulation. If it is an open book fracture, so you got an X-ray done and it is suggestive of an open book fracture. The treatment for this is a pelvic binder. Okay, remember that this is the treatment for the pelvic binder. But the X-ray shows it is not an open book fracture. It is an vertical shear fracture. For this, the management is to give an traction. What do I mean by that? So you are applying an Thomas splint here. For example, in this individual, if it is a right, this is the right and this is the left, what you're having, you're applying the traction on the left side. Application of the traction on the left side will bring back this pelvis into the normal anatomical position, resulting in stopping of the bleeding. The aim is to bring this to normal anatomical position. Pelvic binder is a binder around this. So the open book will become closed book, will result in stopping of the bleeding, or in tampon effect will result in if they get back to the normal anatomical structure or normal anatomical position. Once you have dealt with it, do not log roll the patient. It is kind of not advised to do an log roll. Scoop the patient. Whenever you want to transfer the patient, scoop, always scoop the patient. Then you'll start with fluid resuscitation. If blood products are available, use blood products. Definitive management is either by doing an external fixation plus or minus packing. This is done by orthopedics, so involving the orthopedics. If this is not possible, or you have an interventional radiologist available in your department or in your hospital, then you can do an angiography and see which vessel is the culprit vessel and embolize that vessel and stop the bleeding. This is a high-tech technique which is very commonly utilized in and trauma centers. This can also be done. So it depends orthopedics versus the radiologist. Usually the protocols would have been placed by your department. You will just follow your protocols and see whether to involve the orthopedics or the interventional radiologist. Sometimes interventional radiologists may not be available. They are difficult to be found in every hospital. So most of the time you end up involving the orthopedics and doing an external fixation. I'll just have a quick look if there are any questions. There are no questions. We'll proceed ahead with an head injury. Okay, whenever the patient comes with an head injury, that means we are entering into the secondary survey. Before we enter into the secondary survey, let me airway we are dealt with, plus we are dealt with the breathing, plus we are dealt with the circulation. What about the deformities? Deformities basically in a primary survey is the GCS what you are checking for. If the GCS is less than 9, then it is an indication for intubation. The GCS is very much on the lower side. If it is less than 9, tongue fall will be there that can compromise the airway. That's why this patient will require an intubation. That's all you need to remember in the deformity in the primary survey. Now we are entering into the secondary survey, a head injury, what we are looking out for. Head injury, if present, you need to classify it, or it can be classified depending on the GCS. If the GCS between 13 and 15, you call it as a mild. 9 and 12, you call it as a moderate. Severe injury, if it is between 3 and 8. Okay, it's an isolated head injury is what we're talking about. If there is a head injury and the GCS is less than 13 and the bleeding is not, or you're not suspecting any active extracranial bleeding is present, then you can give tranexamic acid 2 grams IV. This is what is mentioned in the NICE guidelines 2023. Why they want to consider not thought to have an active external bleeding, they have not mentioned. They might be thinking that if it is an active extracranial bleed, you can just apply the pressure and stop it. Why to give tranexamic acid? That might be the logical reason, but the rationale behind this mentioning in the guideline is not mentioned in the NICE guideline 2023. That is the latest one. If it is a pediatric age group, you give 15 mg per kg tranexamic acid. Use the tranexamic acid as soon as possible within 2 hours of the injury before imaging, ideally, but imaging shouldn't be delayed because of that. NICE guidelines when to get NCT scan done. Okay, this is very important. First guidelines is on the adult. Second guidelines what we are having is for the child, that is less than 16 years, more than 16 years for the adult. You're considering adult as in more than 16 years in this circumstance. This is very important. Usually a question does appear on the CT head NICE guidelines. When to get NCT scan done itself is an hot topic to appear in your exam. It might mean adult or an pediatric, they can test you in the examination. What are the risk factors? First thing you'll be seeing is the risk factors. On initial presentation in the emergency department, if the GCS is less than 13, okay, that is one risk factor. You're seeing whether this risk factor is present. Another risk factor is if the GCS is less than 15 after 2 hours of the injury. So the road traffic accident was at around 2 p.m. and he has come to the emergency department 5 p.m. You check the GCS, it is less than 15. That itself is an indication to go ahead. Suspected open pneumothorax, sign of any basal skull fracture. What are the signs of basal skull fracture? Hemotympanum. When you are examining the tympanic membrane using an otoscope, if you visualize blood in the tympanic membrane, hemotympanum. Behind the ear, if there is a bruise, which is known as battle sign. Around the eyes, if there is a bruising is present, it is known as raccoon eye or an panda eye. If any of this following is present, is an indication for you to immediately get NCT scan done. That is, signs are suggestive of an base of skull fracture. After trauma, the patient had an seizures. On examination, there is a focal neurological deficit. For example, there is a diplopia, there is a slurring of the speech, there is a dysarthria is present, unilateral weakness of an upper limb and lower limb is present. If there is more than one episode of vomiting, if any one of this is present, you are getting the CT scan done within 1 hour of arrival to the emergency department. And a provisional report should be provided by the radiologist within an hour's time. None of this following are present, then you will see whether this patient had any loss of consciousness or an amnesia. Amnesia means he doesn't remember after the injury what has happened. If a brief time of 5, 10 minutes, 20 minutes, if he's not able to remember, or he has a proper loss of consciousness. If any of this following is present, then you will look at what is the age of the patient. Is it 65 or more than 65 years of the age group? Is there any obvious bleeding disorders are present, or he is a known case of any bleeding disorders, or he is on any anticoagulants like rivaroxaban, apixaban, or he might be on fexofenadate or warfarin. Any of those drugs he is present on, or he is known to have bleeding disorders like, for example, factor V Leiden deficiency or hemophilia. If any of those following is present, then yes, you need to consider it dangerous mechanism of injury. We will be comparing both the adult and pediatric, then you will have a better understanding. If there is a retrograde amnesia for more than 30 minutes, that means he's not able to remember the events before the trauma for 30 minutes, what was happened. If any of this following is present, then you need to get the CT scan done within 8 hours. Okay, if 8 hours have already been passed since the time of the injury, since the time of the trauma, then you need to get it done within an hour's time. And after the CT scan is done, radiologist has to give an provisional written report within an hour's time. There was no loss of consciousness. Then you need to see whether the patient is taking any anticoagulants or any antiplatelets except aspirin. Aspirin is excluded. Other than aspirin, like clopidogrel, ticagrelol, prasugrel, any of these following drugs, antiplatelet medications he is on, or he's taking any anticoagulants, like rivaroxaban, apixaban, or fexofenadate, any of those kind of drugs he is on, like warfarin, he's on, then also you will go ahead and get the CT scan done within 8 hours of the injury. If 8 hours are already been passed, within 1 hour, you need to get it done. You need to get a provisional report within an hour's time once you get an CT scan done. If he's not on any anticoagulant, no CT scan is required. If he has a loss of consciousness, but none of this following are present, then no CT scan is required. This is what you need to be aware of. Very important. Go through it multiple times. It is not easy to remember in a first glance. It is difficult algorithm what we have here, but heavily tested in the examination. So you need to be aware of. More complicated than is the pediatric one. Okay. What you can see here is the one I have highlighted are the differences from that of the adult. Okay. Suspicion of non-accidental injury is very specific for the pediatric. Post-traumatic seizures is present in the adults. Suspected open and depressed fracture is present in the adult. Signs of basal skull fracture is present in the adult also. Focal neurological deficit is also present in the adults. What changes here? At the initial presentation, if the age of the kid is more than 1 years and the GCS is less than 14, or in an infant where the age is less than 1, infant and the GCS is less than 15. Here it is 14, here it is 15. 14 for anyone who is more than 1 year. If it is less than 1 year, it is less than 15. At initial assessment in the emergency department, if present, that is an indication for CT scan. After 2 hours, it is GCS of less than 15. Okay, remember that usually the confusion will be here. Another thing is if the child is an infant, has a bruise or has a bruise or a swelling or a lacerated wound which measures more than 5 centimeters. If any one of this following is present, then immediately you need to get a CT scan done within 1 hour and a provisional report should be given. Written provisional report should be given by radiologist within an 1 hour's time. None of this following are present. Then you will look out for the risk factors, what is present here in the yellow. Any loss of consciousness which was lasted more than 5 minutes and it has been witnessed by someone. Any bleeding or clotting disorders, what we had discussed previously. Any abnormal drowsiness. What do I mean by abnormal drowsiness? This is the bedtime of the kid and he is drowsy. That is a normal drowsiness. He was supposed to sleep now, so he is sleeping. It is not in bedtime he's already slept and he has woken up. This is not his bedtime, but still he is drowsy. That is an abnormal drowsiness. If there is vomiting in 3 discrete episodes of vomiting, what do I mean by 3 discrete episodes of vomiting? For example, at 1 p.m. he vomited twice. At 2 p.m. he has vomited once. That doesn't mean 3 vomits in discrete episodes. So 3 different episodes it should be. For example, at 2 p.m. he vomited thrice. At 3 p.m. he vomited once. 3:30 he vomited twice. So the 3 different times he has vomited, those are the 3 discrete episodes of vomiting. If present, that is a risk factor. Any dangerous mechanism of injury, antegrade or retrograde amnesia, which is lasting for more than 5 minutes. How many of these risk factors are present? You need to see. If there are more than one risk factor is present, then you get an CT scan done within 1 hour, and a provisional report, a written provisional report should be given within an 1 hour time by the radiologist. If more than one risk factor is present, you will see or you will observe the patient for 4 hours. You can either keep in the emergency department or in the pediatric department, observe for 4 hours. In 4 hours, you are seeing if the GCS is falling down less than 15, or there are further episodes of vomiting, or there is further episodes of drowsiness. If any of this factor is present, then again, once this factor is present, from that time, within 1 hour, you are getting an CT scan done and a provisional report needs to be given within an hour's time. No, none of this following us happened. Then you will be seeing if the patient is on any anticoagulants or antiplatelets. Okay. Antiplatelets, aspirin should be excluded. Most of the time, children will not be on anticoagulants or antiplatelets. But if they are present, then you get the CT scan done within the 8 hours time of the injury. It's already 8 hours have been gone. Then within 1 hour, you are getting it done and needs to be reported within an hour's time, provisional report. None of these risk factors are present, then CT scan is not required. On 4 hours, none of this following is there and no anticoagulant the patient is taking on or no antiplatelet is taking, then no CT scan is required. Again, a difficult algorithm, go multiple times. Questions have appeared on this. Listen to this multiple times if you're having confusions. You need to be aware of what they are mentioning. A 3 discrete vomiting, what they mean by that, you need to be aware of. I mentioned twice in the adult ones as dangerous mechanism of injury, in pediatric ones, dangerous mechanism of injury. I didn't mention what is dangerous mechanism of injury because I want it to be comparatively. Fall from a height of more than 1 meter of 5 stays in an adult is considered as dangerous mechanism of injury. In pediatric, it is more than 3 meters, not 1 meter, more than 3 meters. This is an important difference. That's why we are looking at it in a different slide. A pedestrian and a cyclist struck by a motor vehicle is the same thing. A pedestrian and a cyclist or an occupant or an high-speed road traffic accident is present is the same thing applicable for both adult and pediatric age group. An occupant ejected from a motor vehicle, a high-speed injury with a projectile means the same. These two things are the same. The first thing is the difference where here it is 1 meter in the adult. In pediatric, it is more than 3 meters. In adult, it is more than 1 meter or 5 stays. Sometimes they might give an images of the CT scan and you have to pick up the what is the abnormality. If it is lens shaped, the white color what you're seeing is the blood. Why does it appears? Why does blood appears white on imaging? Because it has iron. Because of the presence of the iron, it appears white in color, same density of that of the skull. So whenever there is a fresh bleed, iron is picked up, it appears white. If it is like a lens shape, then it is an epidural hematoma. If it is in crescent shape, it's a moon shape or the crescent shape, then it is known as subdural hematoma. If it is between the spaces like this is a classical picture which is known as frog appearance. It's supposed to look like a frog, highly imaginary it is, but this is a frog appearance. If it is present, this is known as SAH, subarachnoid hemorrhage. Here you can see black color. Black color density, you need to always suspect A. Same density which is here, it is here. This is black color. This is known as pneumocephalus. If pneumocephalus is present, associated skull fracture will be there. So the external air has entered into the brain parenchyma. This is intraparenchymal bleed. Okay, parenchyma of the brain, intraparenchymal bleed, what you're suspecting here or what you're seeing here. Another thing what you need to see is this is the midline, it is pushed. That means there is the deviation of the midline is present. There is an increased intracranial pressure, what you need to suspect in this individual, if that is the case. Same thing here also, you can see this midline is pushed and it is deviated in this manner, suggestive of an increased intracranial pressure. Same thing holds good here, suggestive of an increased intracranial pressure. This is known as midline shift. This is a tricky, I would call it as a very tricky CT scan. This is nothing but subdural hematoma, paraflaxin subdural hematoma. It doesn't appear like a crescent shaped when it is in the midline. This had appeared in the FRCM exam when I had given long time back. That's why I put up here image. can appear in your exams also, so be aware of it. This is an SDH. It is not a calcification. This is an SDH if it is a trauma. Someone has an head injury. What can you do in the emergency department? What has happened has already happened. EDH, you can't put in burhole, or you're not qualified enough to do in burhole. A subdural hematoma is present, or if there is a subarachnoid hemorrhage is present, intracranial hemorrhage is present. What you can do in the emergency department is prevent the secondary brain injury. That is the thing what you can do in the emergency department. The first step to prevent the secondary brain injury is doing the simple things first. 30 degrees head and elevation. That is the first thing what you'll be doing. You can do it from 15 to 30 degrees head and elevation. The first thing what you need to do it. Airway and breathing. In airway and now this is the first step. Then we are going according to airway, breathing, circulation, deformities, because it is easier to disabilities, because it is easier to remember in that manner. Make sure there is adequate oxygenation. That means PaO2 values are more than 13. PaCO2 values are between 4.5 and 5. For you are given supplementary oxygen, still you are not able to maintain the PaO2 or PCO2 values in this range, then you might have to even go ahead and intubate this patient and connect him to the mechanical ventilator. If you're already placed in endotracheal tube, make sure you're not using an tie. Tie is the one which usually encircles the neck. If it is encircling the neck, if it is little bit tight also, it can hamper the venous return. If it hampers the venous return from your brain, there will be increase in intracranial pressure. That's why they advise to use tapes. Circulation. In circulation, it is advised that you maintain a mean arterial pressure on the higher side. That is 80, mean arterial pressure to be on towards the higher side. Usually 65 is the preferred mean arterial pressure, but you want this to be on the higher side, as high as 80, because cerebral perfusion depends on your blood pressure minus the intracranial pressure. This is the cerebral perfusion pressure formula what you are having. If there is increase in intracranial pressure, BP should also increase. If the BP doesn't increase, there will be hypoxic brain injury in those individuals for that reason. In disabilities, make sure he doesn't go hypoglycemic. Make sure it is in the normal range. If the patient has seizures, do not give it prophylactically any drugs. If the patient has seizures, then treat it with lorazepam. Lorazepam is the preferred one. Treat it with lorazepam. Avoid placing an C-collar. If possible, avoid it. Okay, because again, the C-collar can cause compression over the veins. If there is a venous compression, if it is present, if venous return is hampered, there will be increase in intracranial pressure. In exposure is mainly the pain management. The patient shouldn't be under any pain at all. He should be as comfortable as possible and try to maintain the temperature in the normal range. You're planning to discharge this patient because doesn't have any indication for CT scan. You feel he's an young adult, you can discharge him. So tell him not to be alone. Be with a responsible adult for 24 hours. This is the discharge advice what you're giving. Discharge advice needs to be explained verbally and needs to be given in written also. Tell him have your mobile phone with you. Have it in your pocket for next 24 to 48 hours. Do not drive. Do not cycle. Do not operate any heavy machineries. And do not get involved in any illegal things. Rest for a couple of days. Do not involve in contact sports like football, rugby, boxing, martial arts for next 3 weeks. It is important for next 3 weeks. Avoiding contact sports can be for 4 to 6 weeks. Extended time of avoiding the contact sports if there is an skull fracture. Do not consume any alcohol or take any illicit drugs for minimum of 48 hours. Do not take any sedative drugs like a sleeping pill or tranquilizers unless it is prescribed by the doctor. When to return back to the emergency department? Anything which is abnormal, you think because of an head injury is there, he needs to return back. You can easily guess this out. For example, there is reduced level of consciousness. The patient becomes drowsy and it lasts for more than hours time. He has problem with understanding what other persons are talking, or he has problem with the speaking. He's not able to express himself. There is any loss of orientation. Is not orientation to place, person, or sorry, time, place, person. If there is loss of time, place, person, orientation, then also he needs to come to the emergency department. Unable to walk, loss of balance, cerebellar, you need to think about, needs to come back to the emergency department. weakness in any arms or legs, anything wrong with his eyesight, a pain which is out of proportionate to the injury, which is not going out, which is not coming down with the painkillers what you have prescribed. He feels sick. That means he has started vomiting. Seizures, any episode of seizures. He started noticing any clear fluid through his nose or ears. You're suspecting there might be base of skull fracture. Come back immediately. Bleeding from one or both the ears. Come back to the emergency department. These are the indications when they need to come back. Both needs to be explained to the patient before you discharge and needs to be given in return. Head is finished. Now you're coming to the neck. Neck, what we are dealing with is an Canadian C-spine rule, we call it. It is extensively used in the emergency department. It is a very, very important, heavily tested, like NICE guidelines. Canadian C-spine rule is also heavily tested in the examination. Rule not applicable. When it is not applicable, it is applicable only for the trauma cases. Non-trauma cases, it is not applicable. If the GCS is on the lower side, it is not applicable. Hemodynamically unstable, not applicable. This one, I'll get back to you because NICE guidelines says differently. So less than 16 years, also still you can use it. Any acute paralysis there is known case of any vertebral diseases. For example, cervical spondylosis is present, or rheumatoid arthritis affecting the C spine, or an osteoporosis affecting the C spine. Any previous surgery for the C spine. If the lady is pregnant, then this Canadian C spine rule is not applicable. What does the Canadian C spine rule say? Canadian C spine rule says if the patient age is equal to or more than 65 years age group, if there is any dangerous mechanism of injury, or the patient complains of some paresthesia, some abnormal sensations in the extremities, might be upper limb or the lower limb, then you get an immediately a CT scan needs to be get it done. If none of the above, no, none of this following is present, then what you do is you look at the 5 parameters. Is it a simple rare motor collision? Or the patient was seated in the emergency department at any point of time? Or the patient was ambulatory at any point of time? He was ambulatory means he was able to walk, he was able to get out of the car, or he was able to walk in the road. Anytime he was ambulatory. Delayed onset of neck pain. Soon after the injury, he didn't get the neck pain. It started realizing once he was in emergency department, or he started having this pain once he was in ambulance, or he started realizing that he has the pain after hours time of the incident. Then there is a delayed onset of the neck pain and absence of midline tenderness. Okay. If any of this factor is present, if any, for example, it is a simple rear motor vehicle and none of this following are present, that is enough for you to check for the lateral rotation. You'll ask the patient to rotate laterally 45 degrees, both on the left side and the right side. If he's able to do it comfortably, then no imaging is required. All right. Let us see what is dangerous mechanism of injury here in Canadian C-spine rule. If the fall was more than 1 meter or 5 stairs, an axle load while diving, he has direct impact over the head. That means the entire body weight. While diving, he'll be diving in this manner, and this is the head. So he has stuck the entire weight of the body has gone this. This is known as axle load on the head. Diving is the classical example. A motor vehicle collision where the speed was more than 100 kilometers per hour, or there was a rollover of the car, or the patient was ejected out of the vehicle. Any recreational vehicle, including two-wheelers, we are talking about any recreational vehicle, or it was an horse riding incident, is considered as a dangerous mechanism of injury, holds good for both adult and the child here. Simple rare motor vehicle doesn't mean that it doesn't include rest of the things you can consider if it is not this one. Okay, then you can consider it as a simple rear motor collision, but pushed into the coming oncoming traffic, it's not a simple rear motor collision. Hit by a lorry or a large truck, no. Rollover, no. Hit by a high speed vehicle, high speed means 100 kilometers per hour, then it is not in simple rear motor collision. People get confused when to get NCT scan done. That's why these additional slides have been come across. First indication we will be seeing if the patient age is more than 65 or dangerous mechanism of injury, or the patient is complaining of any paresthesia in the extremities, you directly go ahead and get an CTC spine done. Confusion is in this column. That means it shouldn't be an simple rear motor vehicle. And plus it is along with it, he shouldn't be seated in the emergency department at any point of time. And it shouldn't be ambulatory at any point of time. It should be sudden onset of neck pain, and there is presence of midline tenderness. All of this following should be present. If one of this following is not present, for example, there is no midline tenderness, he was seated in the emergency department at some point of time, that means you're going to the next one and checking for the lateral rotation. You're not getting NCT scan done. To get NCT scan done at this stage, all of the following should be present. Let me repeat it. All of the following should be present. Do not get confused. People will confuse. The patient has a midline tenderness, doctor. Why not get NCT scan done? Because he doesn't, that is not in sudden onset of pain. That's why, because all the five following should be present, then only you're getting a CT scan done. If one or two or three or four also present, it is not an indication for CT scan. All five should be present to get an CT scan done. If none of this is present, not all five, none of this present, then you're checking for the lateral rotation. That means even one, only four is present. Not all of them are present. All of them are not present, then you are checking for the lateral rotation. If he's not able to lateral rotate, then also you'll go ahead and get a CT scan done. So the confusion is in this part. So this is where you need to really concentrate. All 5 points needs to be present to get NCT scan done. If one of this following is not present, then you will be directly going ahead and checking for the lateral rotation. If he's able to do it, no CT scan is required at all. If he's not able to do it, then you get a CT scan done. This is also clear. This is where the confusion is. Do not get confused. So in adult, it is indicated by Canadian C-spine rule, get NCT scan done immediately. There is some neurological deficit done. You got NCT scan done, but still CT scan doesn't show anything abnormal. Then you need to go ahead and get an MRI scan done in adult. In child, the NICE guideline says that you can use an Canadian C-spine rule if the patient is cooperative. For example, a child is 7 years old. He can obey your commands. You can communicate with the kid easily. So communicate with that kid and use the Canadian C-spine rule. And if it is indicated by Canadian C-spine rule, then go ahead and get an MRI scan done. Tested in the last diet itself. A child, when you get an X-ray done, according to the Canadian C-spine rule, if it doesn't fulfill the criteria, then still you're suspecting it might be still there. Canadian C-spine rule I'm applied, but I'm not sure. At that point of time, you can get an X-ray done. Why is it preferred directly to get an MRI scan done, not an CT scan done in a child? Because most of the time, there might not be an associated vertebral fracture in this individual. That means spinal cord injury without, sorry, without uh, spinal cord injury without an C-spine injury, that is an vertebral injury. Okay, spinal cord injury without an vertebral body injury can be present because their vertebrae are quite flexible. Still, underlying spinal cord injury can be present that cannot be picked up on a CT scan. That's why you directly go ahead with an MRI scan done. When to directly jump and not use an CT scan, not to use a Canadian C-spine rule at all. When the GCS is on the lower side, when the patient is already been intubated, then you cannot apply the Canadian C-spine rule at all. Plain X-ray, you cannot get it done, or the imaging, or it is not sure on the plain X-ray. Your continuous suspicion in spite of normal X-ray being there. Some part of the body is been getting scanned. At that point of time, you can include the C-spine also. For example, there is an indication to get an CT head done. In the same sitting, you get an CT neck also done. That will help you. Do not apply an C-spine rule here because you're imaging another part of the body at the same time. Do an imaging of the neck also. That is a C-spine. There is one more criteria known as nexus criteria. Whenever in the stem of the question, if they mention specifically nexus criteria, then only use nexus criteria. If they're not mentioned anything specifically, you're always using the Canadian C-spine rule. Do not use nexus criteria. If there is an midline, what you need to see is there is no posterior midline C-spine tenderness, no evidence of intoxication, a normal level of alertness, no focal neurological deficit, no painful distraction. If the answer for every question is yes, 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 and yes, yes, then no radiography is required. If the answer for any one of this question is no, then radiography is required. That is a CDC spine which is used. This is kind of not used in the NHS, unlikely to be tested in the exam. If they test you, most of the time, it is the Canadian C-spine rule what they'll be testing. Now we are going to the facial injuries. Okay. Head, we have finished. Neck, we have finished. Now we have come to the facial injuries. Before I go into the facial injuries, let me see if there are any questions. Intubation indication is GCS less than 8 or 8 or below 8. Both means the same. You say GCS less than 9 or GCS equal to 8 or less than 8 means the same. Both phrases are same. Whichever you can remember, you can remember. Both means the same. How can GCS be calculated in an infant less than 1 year? You will be using an AVPU to calculate the GCS. Okay, we'll be learning about this in the pediatric. For example, if the kid is alert, he is responsive to the own verbal stimulus, he's responsible to the painful stimulus, unresponsive. Depending on that, you can have an GCS. An alert 15, verbal stimulus 13, painful stimulus around 9 to 10 or 10, sorry, around 8 to 10, what we call it, unresponsive below 8, what we are thinking of. That's what we are thinking of. Pneumocephalus management. Pneumocephalus management, basically, you're suspecting there is a skull fracture. If there is a skull fracture, along with it, if there is any injury at all, if there is only skull fracture, there is nothing needs to be done. Cerebral perfusion, MAP minus ICP. You use an MAP or you use an blood pressure. The logic, what you need to remember, not the formula, what they'll be asking you, because you are an SPA. Clinically, what you are applying, you need a high blood pressure if the ICP is increasing. That is the takeaway message here. Formula is not required. MAP or blood pressure, whatever you are taking, that is not required. You're not calculating here. You are just knowing what needs to be done. How sick we consider return to the ED. Sick means vomiting. It is a sickness. Vomiting, what we're considering, is a layman term used in British English. Sick means vomit. If he has an episode of vomiting, he comes to the emergency department. He's not supposed to have any episodes of vomiting. Treatment for the raised ICP is in detail discussed. For almost 10 minutes, I have discussed. This is the treatment. This is basically prevention of secondary brain injury. Why do you prevent the secondary brain injury? How do you do or prevent the secondary brain injury? By basically reducing the ICP. There are drugs which you can use to reduce the ICP, which we will not be discussing because that needs a neurosurgical opinion to use the drugs. Drugs which can be used is mannitol, and other drug can be used is hypotonic saline. It is a double-edged sword to use an hypotonic saline or mannitol when there is a raised ICP. Because of a trauma, the call will be taken whether this drug needs to be used or not by a neurosurgeon. You are not using on it yourself. All this is preventing the secondary brain injury. How you prevent the secondary brain injury? By reducing the ICP or by preventing the increase in ICP. These are the simple things what you'll be doing bedside so that the ICP doesn't increases. That ends all the questions. So we are entering in and going back to the occipital or the facial bone injuries. You need to be aware of the structures here. Occipitomental view, there are two occipitomental views what you need to be aware of. One is 15 degrees, another one is 30 degrees extension of the neck. This is a 15 degrees extension of the neck. This is the 30 degrees extension of the neck. Whenever they give an 15 degrees extension of the neck, think of orbital floor fracture. Okay. Whenever they are giving an 30 degrees, think of zygomatic arch. This is the zygomatic arch, a zygomatic arch fracture, a zygomatic arch fracture. Look at the zygomatic arch. Okay, zygomatic arch fractures can be picked up very nicely in a 30 degrees, then compared to a 15 degrees view. Orthopantogram for the mandibular injuries, you need to be aware of the structures. And it is like an ring. If there is one fracture at one side, you should suspect there might be another fracture on another side. What are the structures? This is known as condyle. This is coronoid process. This much part is the ramus. This is the angle of the mandible. This is the body of the mandible. This is symphysis menti. This is temporomandibular joint. When to get an orthopantogram done? Trismus is present. Difficulty in opening of the jaw is present, or painful opening of the jaw. There is a malocclusion. When you close your mouth, he is not able to close it properly. There is a malocclusion is present. When you palpate the jawline, there is step deformity is present. There is a breakaway is present. Pain with closed mouth. Whenever he closes his mouth, he has a pain. On examination of the oral cavity, you are noticed and broken tooth. These are all indication to get an orthopantogram. Remember the structures. It is important. Wherever the fracture line is present, that fracture, what you need to name it. For example, if the fracture line is present here, is the condylar process fracture. The fracture line is present here, is a coronoid process fracture. Now coming to the structures here, is the tripod, what we call it, or basically it has four limbs or four legs are present. This is orbital flow. This is frontal process. This is zygomatic arch. This is lateral wall of the maxillary antrum. Okay. You need to be aware of the structures. Next thing what you need to be aware of is this zygomatic arch, or this entire structure. If you put it across and draw an eye here, it looks like an elephant. This is the normal structure, how it's supposed to appear like in an imaging. Okay, so remember this part. Next thing is going to a bar, involving in a bar fight is a very common thing in UK, because after work, most of the time, like in social gathering, they go to a pub or they go to a bar, have few drinks. Once they have few drinks, bar fights are very common. In bar fights, punches are very common to the face, especially to the orbit. Once they punch to the orbit, orbital flow fracture can lead to, can be present. That can be a disastrous thing, or that needs an intervention basically. So someone punches the orbit, orbital floor fracture has resulted. This is the inferior rectus muscle, which has caused the herniation of the inferior rectus. So there is an herniation of the inferior rectus. Herniation means this has come through the fracture side of the orbital flow and enter into the maxillary sinus. That is known as herniation. So this is the lateral view. In the anterior view, it will appear like this. You're suspecting an orbital floor fracture. So you got an X-ray done. How to pick it up? What you will do in an X-ray, what is given to you is you will be comparing the orbital flow and this side. The thickness here is much more compared to the thickness here. That means he had a punch here. The thickness has increased because the soft tissue has herniated into the maxillary sinus. This is known as teardrop sign. Because of this teardrop sign, this is known as teardrop sign. Inferior rectus muscle, extraocular muscle, which has herniated into the maxillary sinus, resulted in a teardrop sign. Sometimes there might be another sign known as eyebrow sign. The black color, what you're seeing here, is the eyebrow sign. Why does the eyebrow sign happen? We know the sinuses are air fluid spaces. There is a fracture. So air escapes here. It is light in weight. It gets settled up over the orbit, resulting in an eyebrow sign, or resulting in black color appearance known as an eyebrow sign. So those are the two things what you need to be aware of: teardrop sign and an eyebrow sign. Very simple to pick it up is to just to look at the thickness. The thickness is increased here. Orbital flow fracture, what I'm suspecting. Few more things what you need to be aware of. Because there is an herniation of the inferior rectus muscle, whenever the patient looks upwards, so this is one eye what you're having, the other eye what you're having. Whenever you ask the patient to look upwards, the normal side eyeball will move, eye will move upwards. On the abnormal side, eye will remain there because the inferior rectus muscle cannot relax. It is obstructed here. That's why it will remain here. So whenever you ask the patient to look upwards, the eye's position are not in alignment, resulting in double vision. That's why he will have an diplopia. This is nothing but double vision is known as diplopia. Why does double vision? Because this is producing one image, this is producing another image. They cannot overlap and produce one image, resulting in double images, resulting in a diplopia. So diplopia and an upward gaze, think of an orbital flow fracture. Along with it, close to the orbital flow, there is a nerve. This nerve is known as here. Close to it is an nerve which is present. This nerve is known as infraorbital nerve. It supplies this part which is colored, including the septum of the nose, ala of the nose, and lateral part of the nose. It is supplied. Okay, and this is the part of the face which it supplies. So numbness, paresthesia, or loss of sensation in that part can be expected when there is an there is an orbital flow fracture. This is infraorbital nerve, which is important. Whenever there is a mandibular injury, a mental nerve injury also you need to be suspecting. Mental nerve will supply this part. Few more things you need to be aware of. This was a difficult question. You need to be aware of supply, the sensory supply to the lower lip. The motor sensory supply is by the marginal mandibular branch of the facial nerve. The sensory supply is by the inferior dental nerve, branch of the mandibular nerve, branch of the trigeminal nerve. So trigeminal branch is mandibular nerve. Mandibular branch is the inferior dental nerve, which supplies the sensory part. Facial nerves branch is the marginal mandibular branch. That is the facial nerves branch, which supplies the motor part of the lower lip. This was tested previously. That's why I've specifically mentioned here. Otherwise, it was basically a very difficult question to answer. Retrobulbar hematoma. Retro means behind. Bulba means eyes, eyeball basically. Eyeball basically they're talking about. Hematoma means blood. Blood is accumulated behind the eyeball. The name itself says what is happening here. So if you get a CT imaging done, this is the eyeball what you are having. Blood is accumulated here. Because the blood is accumulated here, the eyeball is pushed outwards. So proptosis is seen. Because the eyeball is pushed outwards, the extraocular muscles which are attached to the eyeball get stretched. So any movements will be painful movements and restricted eyeball movements he will be having. Okay, so the usual appearance will be like this, what you are having. So you'll be complaining of a severe pain. Okay, it's like in compartment syndrome, what you're having. Severe pain, eye is moved outwards. Even loss of vision might be there if there is compression over the optic nerve. Extraocular movements becomes difficult. This will result in rise in intraocular pressure. For emergency physicians, is the trauma is basically the cause. Sometimes it might be a complication of an surgery like an orbital or an eyelid surgeries, or an AV malformation also can result in. This is a true emergency, needs to be intervened immediately. Lateral canthotomy. So basically, insertion is done here. Lateral canthotomy and cantholysis. The insertion is done there to relieve the pressure. If you do not relieve the pressure, complete loss of vision will be there because of the compression on the optic nerve. So lateral canthotomy, who does it? You as an emergency physician does it. It is a competency which needs to be signed off for you to be a consultant. So this lateral canthotomy as an emergency physician is expected of you to be skilled enough to do an lateral canthotomy. Leaf-Force fracture never tested. Leaf-Force fracture is basically a fracture of the maxilla. If it is a straight line here, then it is known as floating plate or Leaf-Force fracture type 1. Floating maxilla, it is like a pyramid and it is like a triangle. It is Leaf-Force fracture 2. This can cause airway compromise. Leaford 1 doesn't cause airway compromise. This can cause airway compromise. You need to be aware of. Leaford fracture 3 is also known as floating face. It completely separates from that of the skull itself. Face appears as if it has been flattened. It also can cause airway compromise. But the most notorious one is the Leaford type 2, which causes an airway compromise. Now we are going and dealing with the cervical spine fractures. We are looking at the cervical facial fractures. We have dealt with it. Now we are gone down into the spine. That is the cervical spine fractures, what we are looking out for. First one is a C1 fracture, also known as Jefferson's fracture, also known as Atlas fracture. C1 vertebrae is like an polo chocolate, which is sitting over the process of the C2 vertebrae. This process is known as odontine process, also known as PEG. So different names are there, odontine process or PEG, you can call it. It sits over it. So what you can observe here is the lateral. What you need to really observe is whenever they give an open mouth view, there might be a fracture of C1 or a C2 vertebrae itself. They cannot be fracture of C3, C4 because you're not observing at all. It is an open mouth view X-ray what you're seeing here. In open mouth view X-ray, what you need to closely have a look is the borders. The border of the C1 and C2. This is the C2 lateral edge. This is the C1 lateral edge. This is the C2, this is the C1 lateral edge. This is the C2 lateral edge. Are they in a straight line? Are they in alignment? Approximately, they should be in an alignment. In a straight line, they are supposed to be there. If there is loss of alignment, here, the lateral part of the C1, this is the lateral part of the C2. They are not in the straight line at all. It is way away from it. Same thing holds good here. The lateral part of the C1 is not in alignment with the C2, lateral part of the C2 at all. Okay. Why does this happen? Because it is like a polo chocolate. If it fractures on one side, it fractures on the other side also, and it moves laterally. So the alignment is lost. You're looking for this alignment for an C1 vertebral fracture. open mouth view. Dense fracture, also known as odontoid process fracture, also known as pec fracture. This part is known as pec or odontoid or dense. This is the fracture line what you are having. Depending on where the fracture line is present. If the fracture line is, sorry, if the fracture line is the upper part of the odontoid process, then it is type 1. Okay. If it is at the base of odontoid process, then it is type 2. It is below the base, that is, it involves the lateral masses of the C2, then it is type 3. Okay. This is the best prognosis. High risk for a non-union for type 2. It is potentially unstable, requires an intervention for a type 1. What is hangman's fracture? It is in C2 fracture. It is known as hangman's fracture. The name came as hangman's because it was very commonly seen when hanging was taking place in the UK. Now the hanging has come down. Uh, Almost rare anyone undergoes an hang. That's why it is more often C2 fracture, but the name still remain and they call it as an hangman's fracture. Hangman's fracture is fracture at here. This is known as pars interarticularis. Pars interarticularis. Okay. You cannot get this view because there will be one more vertebral body here. You cannot get a proper view like this. This is the spinous process what you're having. This is the spinous process. You cannot get this view. So when you're seeing on the laterally, just adjacent to the vertebral body, if you have a fracture line, then you call it as an hangman's fracture. This is the hangman's fracture. Just adjacent to the vertebral body, what you are having is a hangman's fracture. This can be very much confused with an Clay-Shawler's fracture. Clay-Shawler's fracture is an spinous process fracture what you are having. This is not adjacent. This is not fracture here what you are seeing. If this is the C2 vertebrae, if the fracture is seen here, this is pars interarticularis. That is an hangman's fracture. If this is the spinous process, this part is spinous process, this part is spinous process. Any cervical vertebral spinous process fracture is present, it is known as Clay-Shawler's fracture because it is commonly seen when you are using an Clay-Shawler. How to see in cervical spine? Other cervical spines, how to make out, and you will be just labeling, okay, C2 fracture, C3 fracture, they're not named fractures. Named fractures are Clay-Shawler's fracture, Hangman's fracture, and you have an Jefferson's fracture. Jefferson's is C1, Hangman's is C2, then Clay-Shawler's is spinous process of any vertebrae is Clay-Shawler's fracture. These are the name fractures. Whenever there is a name, highly likelihood of that fracture appearing in the examination. Whenever the cervical spine is given, look at the curvature of the cervical spine. First line is drawn. It will be smooth curved line like this to the anterior part of the vertebral body. It is known as anterior vertebral line. Next one is at the posterior border of the vertebral body. It is known as posterior vertebral line. Next one is drawn at the spinous process, spinolamellar process. It is known as spinolamellar line. The last one is posterior spinous line, what we call it. They should be curved and it should be uniform. If it is not curved, it is not uniform, you need to suspect a fracture. Next thing is each vertebral body, you need to have a closer look to see any compression fractures are present. And also you need to look out for intra-articular spaces, what is present. That is nothing but cartilage, what you need to look out for. Neck injuries. Neck injuries, the only thing what I usually advise to remember here is there are 3 zones in the neck. Anatomically, they're divided into 3 zones. Okay, zone, sorry. What is zone 3? Zone 3 is from the base of the skull to the angle of the mandible. What is zone 2? From the angle of the mandible till the cricoid process is known as zone 2. Zone 3 is from the cricoid process to the clavicle is known as zone 1. Zone 1 and zone 3 usually doesn't have major arteries and major neurovascular structures. Major neurovascular structures are present in zone 2. Whenever zone 2 is injured, most of the time surgical exploration will be required. Zone 3 and 1 might consider and conservative management or sometimes even surgical management might be required. You need not learn the hard science and soft science. It is not required. If you're good at learning things and you have good memory power, then go ahead and learn the hard sign and the soft sign. Otherwise, this is not required from exam point of view. Even clinical point of view, I do not recommend you to remember the hard and soft signs. It is not required. Now we are entering into the spine. We are slightly going down. We are talking about the spine injuries now. Dermatomal distribution, they can test you on. So you need to be aware of. So you cannot go to the exam without knowing what is the dermatomal distribution. For example, thumb is supplied by C6, middle finger is C7, little finger is C8, nipple is T4, xiphisternum is T8, umbilicus is T10, pubic symphysis is T12. Next important thing is L5. That's the dorsum of the foot of the first web space. What you need to remember. Lateral part of the foot is by the S1. Perianal is S4, S5. At least this many nerve roots you need to be aware of before you go to the exam. Spinal cord injuries. Before we enter into the spinal cord injuries and deal with the syndromes, few things you need to be really aware of. There are three important spinal tracts. One is dorsal column, another one is corticospinal tract, another one is spinothalamic tract. What are the functions of it? Dorsal column involves vibration and proprioception. These are the two things you need to be aware of. Corticospinal cord, it is the motor functions, flexion, extension of various muscles. Spinothalamic tract. Spinothalamic tract is mainly for pain and temperature. What do you need to be aware of? Where do they cross? Okay, they enter here. So this is the spinal thalamic tract. Where do they cross? They cross in the spinal cord itself. They go 1 to 2 vertebrae above. They cross and go up to the brain. So they cross in the spinal cord itself. Where do the corticospinal and the dorsal column cross? They cross at the junction of medulla oblongata, junction of the medulla oblongata and the spine. At this junction, they will be crossing. They do not cross in the spinal cord. Next thing what you need to remember is the muscle fiber. So it is the corticospinal tract. It carries the motor fibers, basically nerve fibers, motor nerve fibers. The lower limb motor nerve fibers are carried on the more lateral part. The upper limb motor fibers are carried more on the medial part that you need to be aware of. It is important. Next one is the blood supply. The complete spinal cord except dorsal column, the complete other part of the spinal cord is supplied by anterior spinal artery. The dorsal column is supplied by posterior spinal artery. Okay, only dorsal column is supplied by posterior spinal artery. Rest of the part of the spinal cord is supplied by anterior spinal artery. If you keep this in mind, the syndromes becomes very easy. What is Brown-Sequard syndrome? Half of the spinal cord is destroyed. It might be because of a gunshot injury. Someone has stabbed you from behind. Half of the spinal cord is gone. Because half of the spinal cord is gone, what will be the findings here? Dorsal column. Dorsal column, same side. That's why ipsilateral loss of vibration and proprioception. Corticospinal cord, same side. Ipsilateral upper motor neuron weakness is what you'll be having. Spinothalamic tract, it crosses. Because it crosses, it is contralateral. Contralateral 1 to 2 levels lower. Because 1 to 2 levels lower, it has crossed, and these fibers are coming as these fibers have been injured. So contralateral loss of pain and temperature, what you need to be aware of. Prognosis is excellent. It is good. Central cord syndrome. Classically, they describe it as an hyperextension neck injury they'll be having, commonly seen in an elderly persons. This is usually because of disruption of the blood flow, what you'll be seeing. But what you need to remember, the presentation. Elderly person with an hyperextended neck injury. Motor weakness in the arms are much greater than the legs. Why? It is a central cord. So central part is involved first. That means the muscle fibers which are more medially are involved. The upper limb muscle fibers are more medially. The lower limbs muscle fibers are more laterally. That's why the upper limb weakness is much greater than compared to the lower limb weakness. That is a classical finding what you need to be aware of. Sensory loss, bilateral, it will be sensory loss. It will be like in cape-like loss will be there. Sometimes the sympathetic chain might be involved, resulting in Horner syndrome, which presents with a triad of ptosis, meiosis, that is a constricted pupil, along with an anhydrosis. Anhydrosis is basically dry. There is no sweating at all. And it will be ipsilateral on the same side, ipsilateral. Prognosis again good. Anterior cord syndrome. It is because of vascular insufficiency of the anterior spinal cord. The prognosis is poor because this is compromise of the vascular compromise is present. Complete this much part is gone. So complete paralysis will be seen because of loss of corticospinal tract. What about what about the dorsal column? Dorsal column is supplied by posterior spinal artery, not the anterior spinal artery. That's why it will be preserved. Okay, loss of pain and temperature. That's the spinothalamic tract. Loss of pain and temperature will be seen because it is supplied by anterior spinal artery. So in this way, you can remember this is the comparison what you have written here so that you do not forget. One question usually appears from this syndrome. Again, it is very important. You need to be aware of this. Now entering into the last topic for today, the neurogenic shock. What is neurogenic shock? Whenever there is an injury to the sympathetic chain means it runs at the level of T6 or above it. So the injury should be to the spinal cord at the level of T6 or above it, somewhere from the cervical or T1, T2, T3, T4, T5, T6. Below T6, if it's an injury, it will never cause a neurogenic shock. If it is at the level of T7, T8, T9, it will not cause a neurogenic shock. Because the sympathetic chain is involved, sympathetic tone is gone. There is no sympathetic tone. If there is no sympathetic tone, the vascular tone is gone. If vascular tone is gone, there will be vasodilatation, which will result in pooling of the blood, eventually will result in hypotension, reduced blood pressure. The loss of sympathetic innervation to the heart will result in unopposed parasympathetic activity. To the heart, the parasympathetic activity is from the vagal tone. So from the vagus nerve, the vagal tone will increase because nothing there to oppose. The sympathetic nervous system opposes it. There is nothing there to oppose it. So the vagal tone will increase. This whenever there is increase in vagal tone, resulting in bradycardia, low heart rate. Neurogenic shock is a diagnosis of exclusion. Classical features, what you'll be seeing is low blood pressure along with a low heart rate. If there is an hemorrhagic shock, blood loss is there. Usually blood pressure will be lower side along with high heart rate, what you'll be commonly seeing. A low blood pressure along with a low heart rate, strongly you need to suspect a neurogenic shock. What is spinal shock? Spinal shock is not actually a true shock. Okay, this is temporary loss or depression of the spinal reflexes, what you're seeing because of the injury of the spinal cord. Okay, usually there will be complete recovery will be there over the time. This is spinal shock. This shock doesn't mean blood pressure is on the lower side. Okay, it is an misleading term. Spinal shock doesn't mean this, just it means that your spinal cord has gone into shock. That's why it is not working properly because of the injury. That is the spinal shock. Unlikely questions will appear on the spinal shock because you do not do anything. Usually it will improve on itself. Neurogenic shock is the important one. How do you manage it? So if you are strongly suspecting a neurogenic shock, how do you suspect? It's a trauma case, there is a bradycardia and hypotension. Strongly suspecting, start immediately on the vasopressors because you want to increase the tone of the vessels. Giving IV fluids will not be helpful. In a case where there is a polytrauma, you're not sure what is happening, is in peri-arrest case, at that point of time, start fluid resuscitation. Fluid resuscitation you are given, still not responding. Blood products also you are given. Extensive fluid resuscitation is done. Still the blood pressure is not improving. You need to start thinking of a neurogenic shock at that point of time. If the history is very clear, suggestive of trauma, bradycardia, hypotension, immediately start on vasopressors. The preferred one is noradrenaline, phenylephrine, or dopamine according to the ATLS guidelines. Remember that it increases the vasomotor tone. That's why the blood pressure increases. What about bradycardia? Atropine is a good drug to treat the bradycardia because it is because of the increased in vagal tone, but it doesn't have any effect on the vessels. So vasodilatation will be present there. So it will not increase the blood pressure. So atropine is not a good idea. But in the question, they have asked that what do you do for the bradycardia for this individual? How do you increase the heart rate for this individual? If they are asking in that manner, then you can use atropine to increase the heart rate. Second line of drug is aminophylline. First line of drug remains atropine itself to increase the vagal tone. Sorry. Uh, sorry, to decrease the vagal tone. Atropine is the best drug here. It decreases the vagal tone and increases the heart rate. Again, this is not the drug of choice to treat a neurogenic shock. If they're specifically asking what to do or how to treat an bradycardia in this individual, then use atropine. How to treat a neurogenic shock? You're starting on vasopressor like non-adrenaline, phenylephrine, dopamine, because you are trying to increase the blood pressure. That should be your main target here. I'll go into the questions what you are having before I end here. Anyone has any questions? Because this is the end of the class. Anyone has any questions? Please do ask me. Anyone has any questions? The trauma class is very important. This is the major trauma class is very important. It is as important as the registration class. So do not ignore it. Go through it. It is quite concentration with an extensive information more than in ATLS course. Also, what we are given to you might sound easy, but once you start reading it, you might forget things. So try to make your own notes using the blueprints. It will be helpful. We'll end the class here. Thank you, everyone.